It's my honor and pleasure to welcome you all to the third part of this first module on cord clamping. And this is a webinar organized with UENPS, EAPM, and IPOKRaTES. And it's a great pleasure to know that today there are more than 2,000 registrations to this webinar. We had two fabulous lectures already. And this afternoon, at least afternoon in the European time, it's a great pleasure and honor to introduce our third speaker of this module. And today it's Professor Ola Andersson. He's from Lund University in Sweden and is also a consultant in neonatology at the University Hospital in southern part of Sweden. And he has carried out a number of studies related to cord clamping, early and delayed cord clamping, not only in Sweden, but also in Nepal and probably other places as well. He is the deputy chairman for the steering committee in the National Multicenter Study COPE, which is COVID-19 in pregnancy and early childhood in Sweden. And he's also a co-author of the Swedish National Guidelines on neonatal resuscitation. Now, the topic of his lecture today is stabilization and resuscitation with intact cord circulation, research and experiences. And before I leave the floor to him, I just want to remind you about the Q&A box at the bottom of the screen, which you can send in questions for those who want to do that. And also forgot to introduce my co-chairman, Professor Diego Campos, who will also share the discussion with us. So with this, Ola, heartily welcome, and I'll leave the screen to you, please.
So thank you, Ola, and I'm really standing on the shoulder of giants here, following the very interesting presentations of Professor Weeks and Professor Katheria. But I hope, of course, that I can help and add some thoughts and some knowledge in addition to those very excellent talks. So I'll start my presentation. And I hope, and I actually forgot to share the screen. Sorry. There. Now it should work. So the subject of my presentation is stabilization and resuscitation with intact cord recirculation and the research and experiences. And you have to start with the why. Why are this so interesting, and why do we discuss it or talk about it a lot? And the rationale, it's really started in 1876, where the first study on placental transfusion were performed in Paris by an obstetrician called Pierre Boudin, who already at that time showed that there was a difference of blood transfusion of 92 milliliters between early and delayed cord clamping. And this has been shown further on in different studies in Sweden by partly American researchers in the 1960s, in the UK and in China, and in several places. I think we are quite sure that there is a difference between early and delayed cord clamping of a placental transfusion of 25 to 30 milliliters per kilo. But in addition to the placental transfusion, we have started to talk a lot about the smoother cardiovascular transition that we can achieve. And I have borrowed a figure from Anup Katharia and his co-author Jenny Koo, who did the illustration, where they could have summarized the research by showing that you will have a lung aeration during DCC, which will reduce pulmonary venous return and improve pulmonary blood flow, and it will improve the right ventricular and left ventricular preload and improve the cardiac output, which might have a potential to reduce intraventricular hemorrhage. This has been shown in a lot of very nicely performed experimental studies, and we saw some of those yesterday for those who watched that presentation. Sorry. But except for the placental transfusion and the smoother cardiovascular transition, we have this discussion of how to call it delayed, deferred, late, or physiologic cord clamping, where I would prefer and try to ask people to consider changing the naming to call it sustained cord circulation instead, because as you all know that this cord circulation has been going on all through pregnancy, and what we actually do is just keep it circulating. It's that's the main effect of delaying cord clamping, is to have a continued placental circulation. And by that, we will also have a respiration through the placenta with the exchange of oxygen and carbon dioxide. And to remind you, in preterms, 50% of the total blood volume is in the placenta all through pregnancy up till term pregnancy, when it's 30% of the total blood volume that is in the placenta. Well, this continued placental circulation, or the sustained cord circulation, it has, we use it when you perform the ex uteri intrapartum technique called the exit procedure, where it has been shown that you can rely of the placental circulation. You do a uterotomy, so you can, when you're doing these surgeries, you take out the baby's head, one of the arms, and can perform surgery in the upper, mostly in the throat or the of the baby, but it's still not breathing, and are under general anesthesia, and at least 60 minutes of time is afforded by the placenta under normal conditions, even if you have opened up the uterus. And that's one way of seeing that you can rely on a circulation through the placenta as long as the placenta is adhered to the uterus. But there is also a nice study of some obstetrical colleagues of mine from the hospital in southern Sweden, Nana Wiberg and Karin Kjellén and Per Olofsson, where Nana, she took arterial blood samples and venous blood samples from the umbilical cord at 0 seconds, at 45 seconds, and 90 seconds at the same baby. And they recorded the pH, the PC2, and the O2 in the artery and in the vein. And as you can see, there is the pH lowering, the carbon dioxide is higher after 90 seconds, the oxygen is also higher, but there is differences between the venous and the arterial measurements. And if you look at that, you really can see that during these 90 seconds, there is still a higher pH and a higher PCO2 or PO2 in the vein compared to in the artery, which means that there is still, after 90 seconds, a placenta that will keep oxygenating the blood. And so the why, we should add that this sustained circulation, the smoother cardiovascular transition, and the placental transfusion together will be correcting this is what they think will be correcting the metabolic situation with oxygen, but perhaps also the glucose because of the placenta still working, and as you saw, the pH. This in turn, we think will improve vitality, give a higher APGAR score, reduce the need of prolonged resuscitation, and give us a reduced need of neonatal care. And that in next place will help us with a reduced mortality and morbidity and improve neurodevelopment. That is the rationale or the model that we've been using. But up till this, there is some other problems, and that is that that we have to perhaps think differently if we have preterm or term infants, if they are born vaginally or by cesarean, and if they are vigorous and breathing, or if they are hypoxic and having apnea. And we have also had discussions about this sustained cord circulation in contrast to milking. We have the twins or the triplets or more, and the different types of twin or pregnancy, how to think about that. We have to talk about or consider when to clamp. And then there is this milking and sustained cord circulation. For my, as I don't do any experimental studies, and they were not available when I started reading about cord clamping in mid-2000, this paper of Otwin Linderkamp has always been a very good reference. It's a very long paper, 32 pages with 147 references of a lot of research being done on babies, mostly in the 50s and the 60s. And I think one figure here really summarizes the problems or why we have to consider different scenarios. This is a quite simple figure, but still, you can imagine that in the normal way, you have the fetus, you have the placenta, you have the umbilical vein and the arteries. And if there is a vasoconstriction in the placenta, there will be or a vasodilation in the fetus. The blood volume will go there. But if there is a vasoconstriction in the fetus or in the newborn, there will be more blood in the placenta. The blood has no other way to go. So this is a sort of simple way of thinking of what happens during different scenarios. And when you, what we know, and which we can also think of, is of course in a vaginal birth, we know there is a high catecholamine surge, and that there will be a vasoconstriction with then a vasodilation or a higher volume of blood into the placenta. You might that would you could consider, while when the baby is vigorous and stable and start breathing, we all can see the vasodilation of the baby. We know that the pulmonary vessels open up, but we can all see that the baby goes from being bluish or even pale to being pink in just a couple of minutes. While when we have a hypoxic and unstable baby with apnea, when it's mild, you will also have this vasoconstriction with a high catecholamine surge, in contrast to a late or severe apnea, where you will have a loss of arterial tone and a vasodilation. So we will have two different situations in the hypoxic baby. And that means that we cannot hope for the solution of one size would fit all, or that one timing or one way of handling newborns would be sufficient. And I think that's one of the problems that we have to that we have to address now. And I think that's also one of the reasons that we have 3 different talks on this subject, which I'm really happy, because it helps us to address that there is a lot of questions to think about when it comes to cord clamping. It's not that easy. Well, I just have to remind you of some few studies here that are perhaps the most important right now when it comes to delayed cord clamping or keeping the circulation intact, or having the sustained cord circulation. And in preterm newborns, as you've heard, this very important paper published in November 23 with the systematic review and individual participant data meta-analysis, that's where they compared 3,260 babies with deferred cord clamping, and also looked at milking, where you could see that with this data, there was a reduction in mortality with 32%, or an odds ratio of 0.68, just by waiting to clamp the cord. And they had at this study, it was 30 seconds. And the interesting part, in the other hand, is even if you can see that there was a reduction in death by 32%, when you look at the different diseases that we are usually interested in looking at, like IVH, there was no significant effect, even if it was a low odds ratio, but also sepsis or necrotizing enterocolitis or PDA. There is no significant effects on either of these important outcomes, except for death. So we might still wonder, what is why do baby survive better, or why are there less mortality when the babies are delayed clamped? So the only significant finding they had was the need for blood transfusion was lower. In parallel, there was also performed network meta-analysis, where they looked at different timings of umbilical cord clamping. So it was a short deferral between 15 and 45, a medium deferral between 45 and 120 seconds, and a long deferral, and also milking, and compared that with immediate clamping, and the outcome was death before discharge. And this is the network analysis and the different trials that were compared through that. And the results showed that it seemed from this analysis that it was especially the long deferral that had the significant effect of favoring less mortality. With the odds ratio now being 0.31, which is a very, of course, strong odds ratio, even if it's wide. And there was also hesitancy, because the total trials that was having long deferral was 1 and 3 and 1. So it was only 5 trials with about 580 babies out of all the babies. So this is something we have to look further on and to wait for more results. For term newborns, which was my initial interest, the most important effect, I would say, is the higher iron stores and the less iron deficiency. That has been shown in several studies, including ours from Sweden and Nepal, and one from Mexico and Argentina, and there are more. but they show higher iron stores up to 8 months. And in Nepal, we also saw a reduction of anemia at 8 and 12 months. And I want to mind you that this was comparing less than 60 seconds with over 3 minutes. So even up to 60 seconds was, when compared to 180 seconds, could reduce anemia in Nepal. And we also saw an effect of developmental delay, that there was less of that when you delayed clamping. And in Sweden, we have shown that there is improved scores in fine motor and social domains after delayed clamping. For the guidelines, I just want to mention the two ones that are the most established, I would say. The one is from the American Heart Association from 2020, where they say that for term and preterm infants who require resuscitation at birth, there is insufficient evidence to recommend early cord clamping versus delayed cord clamping, while for preterms, it's reasonable to wait longer than 30 seconds, and for term infants, it may be reasonable. So they found a weaker evidence for term infants. For the European Resuscitation Council guidelines, they have the first recommendation, the first top message is to delay cord clamping, and that this could optimize condition, especially in preterm infants. It's a wonderful slide, this seeing that it has had such an impact to the European Resuscitation Council. And what they thoroughly say when it comes to intact cord resuscitation is that where adequate thermal care and initial resuscitation interventions can be safely undertaken with the cord intact, it may be possible to delay clamping whilst performing these interventions. So before I will talk more about intact cord resuscitation, I would like to mention the study we heard about yesterday, which concerns milking, because I think the results are interesting. And it's the MINVI trial, or the umbilical cord milking in non-vigorous infants, performed by Anup Katharia and his associates. And this was a cluster randomized trial with 1,730 infants that were, when they were non-vigorous, were either had their umbilical cord milked or with early cord clamping. And they had admission to the neonatal intensive care as a predefined, according to predefined criteria as their outcome. And for the outcomes, there was a reduced NICU admission, but it was not significant, because when they were looking at the different when they had to adjust for the different centra in the study, but they could see that milking improved hemoglobin and also had a significant effect of moderate to severe HIE, and also on APGAR score and some other outcomes. But of course, to reduce moderate to severe HIE from 3 to 1.4%, it's a very important outcome, very nicely shown in this study. But when it comes to intact cord resuscitation, I'll just want to repeat this, that we have two things we can use. The one is the transfusion from the placenta, which gives a larger blood volume and will increase perfusion and have a stable hemodynamics. But which we cannot get through milking is this continued placental circulation, which I think is interesting. And again, this would give better results, we think. But perhaps we don't have to do any, we should not do as much less than that. There is this very interesting study from Nepal, where they had an observational study among non-crying neonates. And it was 671 that had an intact cord during stimulation, while it was 3 as many that were cord clamped before stimulation. But what they could see was that in the multivariate analysis, the neonates with intact cord had an 84% increased odds of spontaneous breathing. And I won't get into this, but there is a lot of thoughts about, and some other studies also showing that by not intervening too early, we might see that quite a lot of the babies that we start to resuscitate, they will start breathing and by themselves, and by not clamping the cord, it seems like they will even do that easier or more often. One of the reasons that I talk about intact cord resuscitation today is the study we did in Nepal, where we randomized just before birth 1,560 parents or pregnant women to in need of support of birth, according to the Helping Baby Breathe protocol, that they were predefined or pre-randomized to either intact cord resuscitation for 3 minutes or for early cord clamping and resuscitation at another table. There is a lot of problems with this study, and one is that we had a quite different amount of babies that were considered in need of resuscitation in the intact cord resuscitation group. It was 134 compared to the ones that were considered to needing support at birth in the early cord clamping protocol. It was 97. Still, and there was also a lot of protocol violations. Still, what we could see was, for example, an improved APGAR score at all 3 timings, 1, 5, and 10 minutes. And we also saw an improved oxygenation, which you can see here. The oxygenation was significant with almost half decrease of babies that were, well, there was a lot of more babies with early cord clamping that was not oxygenated well after 5 and 10 minutes. And when it comes to APGAR, there was not a significant effect on APGAR, and it was the same at death. There was 3 babies who died in this study. All those were in the early cord clamping group, but it was not a significant result. When it comes to other studies that has been published and which are quite large, I think the next one that should be mentioned is the Baby Duck trial from Melbourne, Australia, where they did physiological based cord clamping in infants over 32 weeks. And they enrolled 123 infants, and this was after cesarean section. And they performed physiological based cord clamping and or not positive pressure ventilation. And they waited to clamp the cord either 1 minute after the baby was breathing by itself or for 5 minutes. And that was compared to early cord clamping. The outcome here was mean heart rate between 60 and 120 seconds. And yes, so now I had a little movie here. I forgot about that. I'll see if I can. Here you can see how they put a blanket here and some plastic bag where they could put the baby when the baby comes out on the mother's lap. That's and then you could give support like that. And if you look at all the rationales why delay intact cord resuscitation should be effective, this was kind of a disappointment, I think, to the researchers and perhaps for all of us in this community of interest in cord clamping, because they didn't see any differences in the time to the first cry. or in APGAR or in need of respiratory support. Actually, there was a higher proportion of infants in the delayed clamping or in the physiological-based cord clamping that received positive pressure ventilation. And it was considered to be needed to be initiated sooner than in the early cord clamping infants. So in one sense, you might think that there is a similarity to the NEP cord or our Nepal study, that it seems like the babies that were handled or randomized to intact cord got more resuscitative efforts than the early clamped ones. Another study that has been quite recently published is a study from India, where they included both cesarean and vaginal births. And this was a quite large study with 496 neonates born over 34 weeks. And it was intact cord resuscitation or early cord clamping. And they used an expanded APGAR score at 5 minutes as outcome. And this is suggested by the AAP. And you will get, you will have a maximum amount of 17. But if you use oxygen, CPAP, positive pressure ventilation, intubation, surfactant, or chest compressions or medications, you will subtract 1 point, which means that the maximum point is 17 if you are just completely healthy. Anyway, they showed that the extended APGAR score was 15 compared to 14, which was highly significant. But in other respects, there was not a lot of impressing data. There was the same rate of intubation, and there was at least no significant difference in need of positive pressure ventilation and so on. But still, there was a better APGAR score. And also oxygen saturation. These were small differences, but in similarity to our Nepal study. This table I actually comes from Anup Katheria's presentation yesterday, because he presented the 3 trials that has been completed on preterm infants and that has not yet been published. So he said that yesterday, that this is just a short an overview of what has been what seems to what they are about. It's the VENT first from America, the PCI from Italy, and the ABC3, it should be there, from the Netherlands and Germany. And all these studies have been presented their results in different meetings, and at least their primary outcomes has also them been quite disappointing in not showing a lot of positive, or that it's better to give intact cord resuscitation or intact cord stabilization. So right now the data is actually a little bit not very clear if there is any use of stabilizing the babies at all. But still we do it, and I'll just wanted to show you in the VENT first. They had a very simple solution. I got this picture from Karen Fairchild, who is the PI of that study. They had this very simple tray where they also put in a chemical mattress to give warmth, and then they also could have a plastic bag to keep the warmth for the baby. But they put that on the lap of the mother during cesarean sections or in the bed in vaginal births. And they thought that these handles were very convenient when you did transport the baby to the couveuse or the resuscitator or wherever you wanted to transport the baby. And then you have the Concord table, which is commercially available here in Europe, at least. Which has been adopted in a lot of centra. I think it's over 50 centra now in Europe that uses this. And for in Europe, at least, it's the only table or the only solution where there is an warmer ahead. What might be added, because is that there is not a lot of trials showing efficiency with this table yet. We are waiting for the ABC3 to see their more exact results, but from what I have understood, there was still a difference in temperature between early and delayed clamped babies, and as you said, there was well, we'll see if the Concord needs to be shown in scientific trials to see if it's an effective device. The Life Start, Andrew Weeks presented very interesting the development of that 2 days ago. It's been around for quite a long while, and it's also here Anup has shown that it's been used a little bit different for vaginal delivery in United States and in Europe. And the Life Start has been used for the PCI trial in Italy, and the trial, which I forgot the abbreviation for now, on preterms by Leila Dooley, among others, in UK, which have shown effects. So I would say the Life Start is by far the best documented device right now that has also shown that using that you will have positive effects by stabilizing the baby with delayed cord clamping. We did a scoping review where we tried to find papers that has published on intact cord circulation at cesarean sections. And we did look at the bedding or the platform, the position of staff, the sterility and aseptic management, equipment of support of breathing, and to monitor the neonate, and for the temperature. And most of the studies were either using the Life Start or doing it as we could see in the vent first, or the baby duct trial, do it on the mother's lap at cesarean section. The position of staff was very similar, something like the one you can see on the picture above here, where you have the obstetrician in the wound, or in the neonatal staff just to the left of him or her. But we could also see a video by Andrew Weeks 2 days ago where the baby was placed just opposite of the obstetric surgeon. So there is some differences in where you can place the baby. For sterility, there was very large differences. Most of the neonatologists were scrubbed in, while the neonatal nurses not always were. There was most of the studies also reported using the Neopuff to ventilate, but that was also different, how to support breathing and also to how to monitor. Some were just feeling on the umbilical cord, while others are using pulse oximetry. And for temperature control, we could see that there was a small difference, so that for the preterms they seem to be a little bit colder, but as we have seen in quite a lot of studies now, even if babies are 0. some decimals of degrees of colder when they are admitted to the NICU, they still seem to have a better outcome. And there is a discussion of if it is a problem for term infants in this short amount of time that it takes to intact cord resuscitation. Another question that we usually get is the parents' reactions. And Andrew and his colleagues, they could show in a qualitative study that the families are positive about the neonatal care using the Live Start, and that the communication was really important. There was some parents that reported negative emotions as a result of witnessing the resuscitation, but it was rather a small problem. And ANUP has done the same kind of study in United States. I think also this was when using Live Start. At least here, no parents were uncomfortable with this bedside neonatal interventions, while communication is improved. And we have the same experiences here in Sweden, that the communication is really improved with parents. And then there is the staff, and also from this British team with Andrew as co-author, you could show that for the ease of access to the baby, half of the respondents said 50%, 50% said it was the same, 15% said it was worse, and actually 33% said it was easier with access to the baby by using the Live Start. There was a little bit more staff that said it was worse to access the resuscitation equipment, but there was still quite a lot of persons that said it. There was 50% said it was the same, and also the staff was positive when it came to the ease of communication with parents. In the paper by ANUP, they lift also that there is logistical issues, and we could find that in the scoping review about the spacing of staff and the availability of equipment. And when you consider to purchase and use this equipment, or when you consider of doing it without the equipment, you should be ensured that the staff and clinicians are properly trained and educated. I just want to mention that in Sweden, we, because this is usually also a question, is that we perform the direct blood gas sampling, something like this, or with the baby on the mother's belly, and the midwife or assistant nurse, or at cesarean sections, the obstetrician takes the umbilical blood gases from the clamped umbilical cord. So we are right now performing an randomized control trial in sustained cord circulation awaiting ventilation with intact cord resuscitation in Sweden, where we do it in the mother's bed, as we did in Nepal. And we are waiting to get to sample 600 babies in need of resuscitation, and we do, like in Nepal, we randomize them before birth when we need to ask 9,200, and by now it's almost 8,000 included, and we have resuscitated more than 500, so we are closing up to finish. And what we do is that we have this kind of stand with the equipment, with the Neopuff, suction equipment, gas blender, an Apgar watch, and the pulse oximetry or ECG. It could look something like that, or it could be advanced like this. But here you see the pulse oximetry, the Apgar clock, the Neopuff, and the suction equipment. And here is also gas bottles. On this, we had just long hoses to put into the wall. And we are looking at the neonatal outcomes, but we also look at breastfeeding, parental bonding, qualitative studies on staff and parents, and are performing it as a structured implement and research. This is an example of how they take care of preterms in Linköping University Hospital, where they take care of them with intact cord in the bed. Perhaps not the best working position, but anyway. And as the end of my talk, I also need to, or should mention the delivery of placenta. There is two studies, the intact study in Norway, where they in babies in need of resuscitation, or babies that they take out the delivery with the intact umbilical cord and wait to clamp the cord with the extrauterine placenta, and so they will get a placental transfusion, but not in the operating field. And just a few months ago, there was a paper published from Germany about the same intervention, extrauterine placental perfusion oxygenation in infants, with some very interesting results, where the extra placental perfusion group had higher SpO2 and higher also regional oxygenation after birth than in the delayed clamping group. And this is actually continuation of a study performed in Sweden by Peter Karlberg and Björn Westin published in Lancet in 1963, where they had this nice table where they could put the placenta in this now I don't remember the funnel, I think it's called. So they put the placenta here, they had the baby here, and here the baby could be put in cold water. So they applied hypothermia and extrauterine placental transfusion. And in this study, I think it was 80 infants that were needed in severe asphyxia, and all were resuscitated successfully by doing this. So history has a lot to learn us, and I think the really important thing right now is to remember is that there is still a lot of questions. When you want to or are interested in intact cord resuscitation, you need to plan it thoroughly. You really have to educate and train your staff. You should absolutely document or record your data, and please share it, because as I hope you have understood from my presentation, there is still a lot of questions in different matters to be answered before we know the definite answer. So by that, I want to thank you for listening, and I'll leave for questions.
Thank you so much, Ola. A wonderful lecture, really brilliant. We have approximately 10 minutes for questions, and I see that also IPOKRaTES has joined us. So I will call upon Andrew Weeks and IPOKRaTES if you have any comments to start out with.
That's very kind, and thanks so much, Ola. It's always fascinating to hear you talk. I was interested in one of the things which I've never quite understood is the delayed cord clamping in the situation of shoulder dystocia. It seems very clear to us, and we take great care in Liverpool, if we've got a shoulder dystocia, to rush in with the Life Start trolley, because they seem to be the very ones that we should be delaying cord clamping in. But then they said to me, so Prof Weeks, why is it? And I always struggle. I make something up at the time and then say, oh, infant vasoconstriction, therefore. And sometimes I say, well, the cord might have been trapped as the baby's half in, half out. But
I think you're right about the cord, but I know Anup has written about this, and Judith Mercer has written about it, that we think it might be that the cord is squeezed, but as the arteries are will stay, there is a higher blood pressure. So there might be a possibility for the blood to still be pulsating out to the placenta, but either there will be a high pressure, so the umbilical vein will be compressed, because you usually see this very nicely in the blood gases, that you have almost normal blood gases in the vein, but affected blood gases in the arteries. So that might be at least be one of the explanations. The other one would be, at least Judy thinks that perhaps just the pressure of the uterus when you are in this very, very tight position will help well, will makes it harder will push the blood into the placenta.
Yeah, I mean, it was the vasoconstriction story which you told, which I thought, I wonder how much vasoconstriction you're getting in a shoulder dystocia baby.
Yeah, you will have a lot. You will have a lot of vasoconstriction in the.
It's actually just holding the blood back in the placenta. Thank you.
Okay, thank you. Anep, do you have any comments before we move on?
Yeah, just a few brief ones. Again, great presentation, Ola. Always learn a lot from you. A few things about sort of my theories, and I see this in the chat as well. I think, with delayed cord clamping and intact cord resuscitation, particularly for the term baby, I think we have to be careful when we initiate mask ventilation, because I think, the initial benefits, I think, really of delayed cord clamping is letting that baby sort of have some transition. And I think some of the worry I have with the trials, as you presented, with the babies needing more resuscitation, is as soon as you give the ability to a provider to get a mask on a baby sooner than normal, which, with delayed cord clamping in general, we wait till the baby's transition typically to get the baby on a warmer. I think this is what we have to be cautious of. Because we shouldn't be seeing more resuscitation in babies with their cord connected. It goes against everything I've learned from my midwifery colleagues. And so I think that's what we have to think about for the term babies. And then for the extrauterine placental transfusion trials that I remember reviewing that study, I think we have to also be cautious if you get the baby to the warmer sooner because you're bringing the baby and the placenta over, you might see better oxygenation in NIRS compared to leaving the baby with the placenta still in the uterus because they haven't had a chance to get all this extra oxygen support. So I do think we need better trials to compare intact cord resuscitation on the mother's abdomen compared to extrauterine placental intact cord resuscitation to see whether or not it's truly better. Because I think one of the concerns I always have is you do lose that endogenous maternal gas exchange that would be happening if the placenta still was in the mother. So just two side comments, but I think the studies are great, and I'm really excited to hear about the SAVE trial. Hopefully next year, fingers crossed.
Yeah. Well, I completely agree that's why I wanted to mention about, because we usually don't talk so much about the placenta still working, still doing its job after birth as long as it's adhered, and I personally think that's something we should consider more. So thanks.
Thank you. Diego, do you have any comments, or should we move on to the Q&A?
Well, maybe just one question which I think is also in the chat, which is something that worries us as obstetricians regarding the temperature of the newborn, and some concerns that it may be affecting the temperature and that may be important in some newborns. The question is the need, because we see all this expensive equipment with overhead heaters. Has that been shown to be better than other more simple and less expensive solutions outside the setting as well as inside the setting?
No, well, Daniele Trevisanuti, who wrote a review about this, about overheat warmers, and compared with the chemical mattresses, and they rather were a little bit hesitant about that. It's harder to control the temperature of the baby with overheat warmers. We are all used of using it, and we are very.
We lost you, Ola.
Sorry, you lost me. Okay.
At least I did. Yeah.
Fine for me.
Yeah.
Okay.
So no, so but if you look at the data, it seems that you will have the same results by using a warmer mattress and a plastic wrap, as at least for a few minutes. It's perhaps something quite different if you are working for 15 or 20 minutes.
Okay, I think we have to go on with the questions, and we have actually the two first questions are about disappointing results with the intact cord resuscitation. The first is from Elizabeth Setter, and the second for Lizzie. Elizabeth, says, do you think that the somewhat disappointing results of studies on intact cord resuscitation could have to do with the fact that you intervene earlier because you can and not because you should? And then Lizzie asks, do you have any thoughts about why these large studies are not showing clinically significant benefits?
Well, I think that we still want to read their papers to understand their data, but for the ABC3, they compared quite a delayed clamping without intervention or with giving resuscitation or stabilization efforts. So of course there was already the effect of delayed cord clamping in that study. So there might be different answers to the different questions. Some of them, I think, when you clamp, perhaps you clamp too early in some of the studies. But it's no, I don't have any good answer. I don't know if Anup or Andrew has something to add.
Well, the only thing I'll add is that I'm still uncomfortable. I think you made the point very well that this relating to minutes and 1 minute or 120 seconds actually is very crude, isn't it? It's not really, I think, what we should be doing. We should be looking at the baby in front of us and seeing what care they need and what blood they've taken. And so it's difficult, I think, at the moment, because we do it all according to these very blunt instruments of timing. And I think we need to move on. And I think future studies will move on to a far more nuanced approach, where you clamp the cord according to the fetal needs. But we haven't quite identified exactly what those parameters are. Time's as good as we've got, and time's not really the ideal.
Can I just add one comment as
please,
well?
Please.
I think the challenges, and at least speaking to some of the investigators from the trial, is that I think we try to make intact cord resuscitation too simple for the preterm baby, and it's not. With severe growth restriction, when you have a second twin with a posterior placenta, these babies that have really short cords and you have to get really close in the field, and you don't have room to get the trolley on the baby, and the baby's on a soft surface, and you don't have the ability to fully monitor babies, a lot of these babies don't get really good resuscitation. And I think it's very provider and center dependent. If you talk to some of these trialists, and I will tell you in my own trials, oftentimes I would be the one going in just to make sure these went well. And this is where I think training is so key. Neonatologists and the providers are not used to going into a sterile field, crowded, with 2 obstetricians and a scrub tech and trying to fit in a small space. So we really have to refine this, work with our obstetrical colleagues. I think, Andrew and the group in the UK, you guys have been doing this for so long. And I think it's not very clear to other people when they're listening to us present these data that we could just go out and just do this. And I think that's the part, I think in trials we're seeing. I do think it works. I just think it needs to be optimized, and that's why we're not seeing the same sort of benefits in these large RCTs. At least that's my opinion. And I think as we get better, we may be able to show that.
Okay, thank you. Very valuable comments. There's a question here from Mari Kinoshita. She's thanking for an inspiring lecture and asks, what are your thoughts about delayed cord clamping in countries with less IVH and more jaundice, which may be some factors related to why DCC is not yet common practice in my home country of Japan? I think we touched this question yesterday also, Ola.
Yeah, well, I can only answer from our Nepal study where we had 540 infants and we compared early and delayed cord clamping, and we had no higher risk of jaundice or need of phototherapy in that material. But as I also mentioned, it seems like that infants that perhaps had an affected liver function of different reasons might be at risk of hyperbilirubinemia. So at least you should monitor it. But when you compare that to reduced mortality for preterms or perhaps then less anemia at 1 year of age in low and middle income countries. That might be a price that you have to be able to handle, a problem you need to handle.
Yeah, so I think this is an issue we will probably come back to
Could I
also in the
just
future.
comment? I think it's interesting, the Japan comparison, but of course, a lot of my work is in Africa, and certainly in areas where there's very high levels of iron deficiency, then actually iron deficiency becomes a major issue, and the unavailability of blood transfusion for in neonatal units is a big issue. And so the balance all changes then, doesn't it? And in a you know, the problems in a tropical climate of hyperbilirubinemia isn't such a big one. The problem actually is death and iron deficiency anemia. And so the whole balance then tips again, and you need almost to repeat those same studies in those areas, because I'd suspect you get very much greater benefit. But until we do the studies, we won't know.
We have a question from Nestor Wayne here from Argentina. Hi, Nestor. He asks, he refers to their studies where they've been weighing babies the first minutes of life and showing that there is a transfusion from the placenta to the baby even after 2 minutes. So he asks, I do not know how important is resuscitation with the intact cord, but the fetal blood belongs to the infant and 2 minutes is not enough. Or as a statement from him.
Yeah, I completely agree. All the data that has shown long-term effects is on infants that are either 3 or 5 minutes delayed cord clamped. So for term infants, but again, that's what I tried to show. We have the term and the preterms. We have the cesareans, and it seems like when an elective cesarean, the blood transfusion, the placenta transfusion moves much faster. And because I suppose it's because there is less catecholamines, lower blood pressure in the infant, but especially we haven't studied a hypoxic infant that has a slower heart rate or a less strong heart to pump the blood. Because I didn't get into the mechanism of placental transfusion, but I really also think we have to consider the importance of having a strong heart to get a full placental transfusion, at least in a short while. Otherwise, you have to wait even longer, perhaps.
Okay. Well, we're a little bit over time, but I think if we can go on for a few more minutes, we could go through all the questions, if you don't
Can I
mind.
just make a brief comment?
Please.
Just about the placental weighing. When we did this, well, Lilia Dooley did it in Nottingham, but we saw huge variation from baby to baby. And it wasn't, you might expect that every single baby, it just comes gradually across. But if you look in the papers which Lilia produced, there's huge variation from baby to baby. Some it goes across within a minute, others takes 5 minutes.
Okay.
Again, a timing is not a good indicator, but I don't know what's better.
Yeah, I think this is a very important practical point. Let's see now. There's several people are concerned about the temperatures, thermal control, and there's one asking, Emil Okulu, how do you maintain the body temperature of the baby between the legs of the mother with the mother on the bed?
Yeah, for the safe trial, for the safe trial, we have a clean cloth. So because there is usually a lot of blood or ammonia or it's wet amnion fluid. Thank you. But so we put on a dry cloth under the baby, and then we dry the baby, and for these 3 minutes, either we just do that to dry the baby for the term ones, and we haven't seen any problems with hypothermia. But we will, of course, have to address that more in the final results. But there has been a nice study by Doug Blank also in Melbourne, thinking about if the baby is warmed by the circulation, because there will still be then circulating warm blood from the placenta into the baby while you have the cord intact, which is an intriguing thought. At least I can't see that I have the evidence for that, but I think it's an intriguing thought that the baby is actually warmed by this warm blood coming from the placenta.
Okay, and now quick answers, please. Should we be milking cords if baby is born in the amniotic bag and placenta has been detached?
No.
No. Okay.
How's that for a quick answer? You know?
Yeah.
That was a quick one. The next one from Isabel.
I can also say no.
No.
Well,
Okay.
if
Well,
it's
that was
born
a
in
clear
the
answer.
sac and you've taken the placenta and the baby out, the neonatologist might not like it, but hand the whole thing to the neonatologist, and they can there's no problem. The baby can take what blood it wants in whatever time it wants.
Yeah.
Okay.
Rather-
Then from Isabel. Hello, Isabel. Are we interfering with lung vascular filling when positive pressure ventilation intervention is provided too quickly?
Oh, that's a really interesting question. I'm the wrong one to answer this. I think that the Melbourne team has looked at that, but if we are interfering or if we are helping, I think Anup had some very interesting slides on that yesterday, and about giving at least CPAP, and that will help while having delayed cord clamping, that we will have a higher oxygenation. So
Don't you think it also depends on the condition of the baby?
yeah, again, absolutely.
Anup, is you there? Are you there? Comment on this?
So the only thing I'll say from the animal studies, I know in buffalo, they did demonstrate decreased pulmonary blood flow when a sustained inflation was given during an intact cord resuscitation. But I haven't seen anything from the Melbourne group saying diminished blood flow with positive pressures. But again, these are lambs that are intubated, and it's a very different model. So I think for the preterm baby, you're looking to recruit lung. But I think if you have an aerated lung already and you're giving a big breath, I'm sure that's not beneficial for pulmonary hemodynamics. So I think that's the thing we have to be careful of a term baby or a preterm baby that we're trying to support.
And I really think that having a sustained cord circulation, or by delaying cord clamping, we give ourselves time to wait to intervene, but we need to be to consider what should help us not intervening. Should it be just a rising heart rate, or should we look at the saturation? I think we need to reconsider the when to start doing resuscitation measures.
I think there's been a bad concept in medicine that always quickly is better. And we've certainly run into it with cord clamping, where we found it's actually harmful. And you see the same with delivery of the placenta at cesarean, which I spoke of a couple of days. You see it and you rush in to scoop it out, and you cause bleeding itself. And I think we also need to be careful with the neonate, that we don't run into the same trap of just because delay is a problem, it doesn't mean that there's not an optimal time, and that rushing in and doing things too quickly is also a problem. So we need to realize there's problems at both too quickly and too slowly.
Yeah. Okay, and there's a question here. I think we have touched it before. What's your opinion regarding the other complication of delayed cord clamping or umbilical cord milking, like polycythemia, hypoglycemia, owing to polycythemia? Do you have a quick comment on that?
Well, it hasn't been shown that the polycythemia that follows is of any clinical importance. So
I think it's quite interesting looking at the normal ranges, because the normal ranges of neonatal hemoglobin always tended to be done on early cord clamp babies. So if then you delay cord clamping, then you go, oh, it's outside the normal range. Well, no, it's different. And what we should have done is said, well, the optimal cord clamp babies, that's the normal hemoglobin. And actually, when you early cord clamp, you bring it outside of the normal range. So our normal ranges from history are a problem, I think.
Yeah.
And as I just must say, I haven't mentioned it, but I think that we have this baby that has controlled its own blood volume for 28 weeks or for 40 weeks. It's been fully competent in controlling its own blood volume. So we might consider that a vigorous infant, preterm or term, might be able to control that also after birth, and will let the exact amount of blood that it needs, or that it's in which is beneficial, might be up to the baby to decide, which is completely different from the asphyctic baby, of course.
Yeah, I think we have a few more questions, but I think we have touched most of them. There's one question here about applying PEEP as opposed to simple stimulation. I'm not sure that is so much related to cord clamping, or do you have any comment, Ola?
No, I think that comes back to what we have talked about, that perhaps there is some studies showing that we might disturb the baby when it's just trying to start breathing by itself. We will disturb it by applying PEEP, but it's still, again, what kind of baby do we have in front of us? It's really very difficult to give any good advice here.
Yeah. Okay, I think that's most of the questions. There are a few we haven't read, but I think we have touched those topics. Diego, do you have any more comments before we close?
No, I think not. I think we've touched on most of the, if not all of the questions. I think we're okay there.
Okay, so then it's my pleasure and honor to thank you once more, Ola, and also to thank all the three speakers of this module, Andrew Weeks, Alm Kateria, and Ola Andersson. It's been great, and I would like to thank the audience and thank